We'll be discussing about neonatal thrombosis, and I'll be presenting the first case for today. I'll be the presenter, Dr. Ankit Jain, and Jain sir will be moderating my session. So, coming to my case, this was an outborn baby. This baby was born to a 35-year-old mother with a history of gravida 6, 5 abortions. All these abortions were the first trimester abortion with history of APLA positive status in mother, as well as there was a significant history of gestational diabetes mellitus, as well as preeclampsia and multiple fibroids in uterus in mother. In the antenatal period, this mother, in view of equivocal results for anticardiolipin, but due to bad obstetric history and 5 abortions, this mother was treated for APLA, where she was given IVIG every 3 weeks for the first trimester, the aspirin as an antiplatelet agent, and low molecular weight heparin, that is enoxaparin, for subcutaneous OD for entire conception period. While her gestational diabetes mellitus was managed with only diet modification, she did not require insulin or any oral medication. And preeclampsia diagnosed at 7 months of pregnancy, which was also treated with oral medication. Outside, and when this baby came to us, the following history was obtained on referral. The baby was delivered at 34 plus 6 days in view of poor anesthesia on routine checkup. So hence the baby was taken for emergency LSPS. On birth, baby had an APGAR score of 7, 7, and 8. There was significant respiratory distress at birth, and baby was given CPAP support for 3 days. The umbilical vein catheter, according to the referral report, was inserted on day 2 of life. In view of sepsis screen positive status, where there was a thrombocytopenia, the patient was started on berocolistin and vancomycin. Feeds were started for this baby on day 3 of life, but baby showed poor tolerance to feed, hence the feed was stopped on day 4, and feed was reintroduced on day 6 of life. There was also a history of 2 units of FFP and platelet transfusion outside. Now, on day 6 of life, baby was noted to have bilateral limb changes in form of cyanosis and ischemic changes. And in view of these worsening ischemic or cyanosis changes, baby underwent Doppler study outside, which was suggestive of external iliac artery thrombosis. Hence, the baby was referred to HIMS Dehradun. Baby presented to us on day 9 of life, where on presentation, this was the significant change of bilateral ischemia of foot along with toes. As you can see in the picture, there's a significant bilateral ischemia of both the limbs, especially right more than the left. Along with that, there was early gangrenous changes on 2 of the toes in the right foot. Now, central line was in situ, which on X-ray review from outside, it appeared to have the course of UAC, though the referral card said of a UVC. So a decision to remove it was taken in the emergency itself. On examination of the limb, as I mentioned earlier, to differentiate between arterial and venous thrombosis, baby underwent into examination clinically. There was a clear demarcation line between ischemic changes as well as non-ischemic part of the lower limb. There was no swelling in the lower limb, thus pointing towards less chances towards venous thrombosis. The right-sided dorsalis pedis artery was not palpable, while all other peripheral pulses were palpable. The perfusion index was monitored in all 4 limbs as well at the presentation, as well as for monitoring purpose. We monitored the perfusion index, and it was noted that the lower limb perfusion index was on low from the upper limb comparatively. The upper limb had a perfusion index in between the range of 0.8 to 1, while the lower limb in the right side had a perfusion index of 0.3, while the left limb had a perfusion index of around 0.6 to 0.7. Both the limbs had a low perfusion index, right more than the left. The 4-limb BP was taken, which was normal. A Doppler study was done for bilateral lower limb vessels as well as the abdominal vessels, which showed absent flow in the right external iliac artery, right anterior tibial artery, and right dorsalis pedis artery, while left limb vessels showed normal triphasic waveform in all the vessels. A CT angio was done, which again showed reconfirmed our Doppler findings, which showed a right non-opacification of right common iliac and external iliac artery, with reformation of the right common femoral artery to the inferior epigastric artery. So baby was started on unfractionated heparin after giving a bolus dose of 75 unit per kg. Baby was started to maintain maintenance dose of 28 unit per kg per hour, and this heparin dose was titrated according to APTT report. Though we faced certain challenges, I'll be discussing it later. Samples for the thrombophilic sample was collected. Hematologist opinion was taken for this entire case, and in also on the history of maternal history of Hapla, who advised in IVIG and methylprednisolone for the same. The antibiotics which were being given outside, out of which merocolistin was continued and a culture sensitivity was sent, though our HIMS sepsis screen was negative. By day 14 of life, baby started to show improvement, but the gangrenous change persisted. The thrombophilia report had come till now, and it was suggestive of decreased protein C activity, which was around 44%. The lab which we sent to had a normal range of 60 to 140%, but literature mostly mentioned a low protein C value of around 15 to 20% is considered significant, while antithrombin activity was mildly decreased to 77%. The lab values were in the range of 80 to 120%. But we have to remember there was a confounder. The baby was already on heparin infusion when these samples were collected. So heparin infusion might alter the reports of protein C as well as, and especially antithrombin activity. By day 14 of life, the antiplatelet agent in form of aspirin was added to line of treatment. As we can see in next 4 to 5 days, we can see there was significant changes in both the lower limb. The left limb started to become quite well perfused, except the toes, while the right limb, the perfusion of ankle had become significantly better, but the toes were still under perfused or ischemic changes were present in the toes, especially the 3 toes. Now, other investigations done were MR angiography for this baby, which was normal in study, and ECG was done, which was also in normal study. Renal Doppler was done to rule out the renal vein thrombosis as well as renal arterial thrombosis, which was also normal in study. In view of APLA equivocal results in mother, APLA workup for the baby was done, and to rule out antiphospholipid syndrome in newborn. It was also negative for all the factors which we sent. Factor 5 latent mutation was sent along with thrombophilia workup. It was also negative. By day 26 of life, the baby had a methylprednisolone was tapered, and after 3 days of pulse therapy, we gave a 30 mg per kg initial first 3 days. Though there was a lot of controversy, and we did not find a correct indication or a dosing of methylprednisolone and their uses in newborn period and their use of pulse therapy. But according to hematologist opinion, we went ahead with the methylprednisolone 30 mg per kg for 3 days of pulse therapy. Afterwards, baby was taken on low dose methylprednisolone for 1 week, and after that, baby was shifted to oral dexamethasone, which was in the tapering dose for 4 weeks. On day 26 of life, baby was shifted to injection enoxaparin from unfractionated heparin, and mother was taught about how to give injection enoxaparin for the baby. A plastic surgery review was taken for the gangrenous changes in both the toes, who advised for conservative management in view of dry gangrene. Ophthalmology review for the eye changes or thrombotic changes in the eye revealed ROP stage 2 in zone 2 at a single 2 o'clock position in the right eye, while normal vascularization in the left eye, which resolved on its own on the next follow-up periods and OPD periods. By the time day 27, as we can see, left limb had become completely normal, while the right limb had a gangrenous change in the grade 2 and the small gangrenous patch in the second 2. Patient was discharged on day 29 with the advice of tapering dose of oral dexamethasone. The entire plan was explained to them how to taper it, and plan to stop at 6 weeks of life. The tablet aspiration should be was advised to continue at least 3 months of age, which may have to extend further, as well as enoxaparin, which was taught to mother, and which may require till at least 3 months of age, and after that it may have to be continued. A repeat thrombophilia panel plan was considered at 3 months of age. Patient was is advised for regular OPD follow, and vaccination plan was explained to them in view of high dose of steroid was given at birth as well as IVIG was given. So entire immunization plan was explained to them, like post stoppage of a steroid, they may require to give at least 1 month period for giving live virus vaccine, and for IVIG up to 8 to 9 months before giving any live vaccine for the baby. This was explained to the patient. So it was a happy discharge from both the parents, and they went happily home. And on OPD visit on day 35 of life, we can see the right toe is completely, the half of the right toe is completely gangrenous, while the second toe started to improve. And by day 50, this gangrenous change of the right toe had fallen by itself. There was the while the left second toe had improved significantly. Now, what was the challenge we faced during the management of
I think we lost you.
heparin instead dose of 50 unit per kg per hour? Our 4 hourly APTC report was in the range of 30 to 40 only. But since we had reached the maintenance infusion, one of our highest doses, and as well as the baby was showing clinical improvement, we did not increase the heparin infusion further for this baby, as well as the risk for heparin-induced complications like HIT or bleeding was there. That had to be considered while giving the maintenance dose. Second was, as I mentioned earlier, the dose of steroid or dose of methylprednisolone was not clear completely in literature. What dose can be used if we are suspecting autoimmune condition? Whether to use pulse therapy or not to use pulse therapy in these type of cases. Third was, there was since there was a initial period, there was a hesitance for the compliance in the mother. We went back to literature and found that there is still oral anticoagulants are not very much available for the newborn, and only 6 oral anticoagulants are under different type of clinical trials, like for factor 10 inhibitors in form of rivaroxaban, apixaban, edoxaban, and betrixaban are the factor 10 inhibitors, while factor 2, bevaluridine, and dabigatran are the 6 total anticoagulants which are under different phases. Like all the 10 factor 10 inhibitors are in the range of phase 1 or phase 2 trial, while the most advanced is the bevaluridine, which has been used in certain cases, and there were studies of usage of bevaluridine under 6 months of age also, in the doses, different doses of 0.125 to 0.25 mg per kg, but still it is not completely into the market. Dabigatran is the second one which may come to the market because it is under phase 3 of trial. But all the other factor 10 inhibitors which we are for being commonly used in adults have are under various stages of trial for the newborns. There was again a second fourth dilemma we had faced was whether to go ahead with thrombolysis or not to go ahead with the thrombolysis in the baby. But since the baby was showing significant improvement in form of ischemic changes and being in better perfusion index day by day, which was being monitored objectively for this baby, we chose to not go ahead with thrombolysis. As well as we need to consider whenever we are going for thrombolysis, there is minimal data which exists in newborn population regarding the thrombolytic therapy, about its indication, safety, efficacy, what agent should be used, what is the duration of therapy, whether what will be the monitoring guideline, as well as the technical expertise is a challenge for a neonatal thrombolytic therapy. But it was definitely considered. Since the baby was improving clinically, we did not go with thrombolysis in this baby. And the fifth, which is one of the most common problem as we all face in our daily life, is the cost of thrombophilia panel, which is quite high, 15,000 rupees, as well as monitoring of factor 10A, which is recommended whenever we are giving the low molecular weight heparin. The availability of this test is also low, and wherever it is available in India, it is costing around 8 to 10,000 just for monitoring factor 10A level. So these were the one of few challenges that we face during management. What will you should take home as a message? The central lines are the most common reasons for the neonatal thrombosis. Usage of diluted heparin infusion is important and for USC umbilical arterial catheter to prevent catheter blockage and to reduce to a certain number of thrombosis cases. Early identification of all the cases of vasospasm and thrombosis of immediate removal of central lines are important, as well as looking at the course of UVC, UAC, and deciding where your line has gone and monitoring them. In cases of non-improving cases, thrombolytic therapy may be considered in neonates. Thank you.
Thank you, Ankit. Now I will request Varia team to please take over for the next case presentation.
Recording in progress. Am I visible? There's a screen visible?
Yes, sure. Go ahead,
Yeah.
please.
So I'll be starting with my presentation. Good morning, everyone. So the first case, 3-day-old male child born to a G5 spontaneous abortion for T2 L2 mother at 36 weeks of gestation. It was a twin delivery, birth weight of 1.9 kg. This was the twin 2 of the DCDA twins, delivered via LSCS in view of twin gestation. He was referred to Wadia at 62 hours of life in view of discoloration of the right hand extending up to the elbow, noticed since the last 1 day. So significant antenatal history. Mother had tested UPD positive 4 times, followed by pervaginal bleeding after 1 to 1.5 months of pregnancy. No ANC visit or ANC scans had been done in all these 4 instances. The present pregnancy was a spontaneous conception. Mother was started on weekly injection progesterone for the conservation of pregnancy. 4 ANC scans were done during the entire gestation, which all of them were within normal limits. Mother was a known case of gestational hypothyroidism on tap thyronorm at 50 micrograms. Otherwise, there was no significant antenatal history. So course in the outside hospital, the baby was born by LSCS, cried immediately after birth. At 2 hours of life, the baby developed hypoglycemia, for which they had secured an IV line, a peripheral IV line, which was removed on the second day, and a new IV line had been secured on the right hand. On day 2 of life in the morning, father observed swelling over the right hand, after which the IV line was removed and discoloration of the forearm was observed. This kept progressing till evening, after which the baby was referred to us. So on admission, when we received the baby, there was discoloration of right hand up to the elbow with darkened nails. A tenderness was present over the right forearm. Radial and ulnar pulses were not palpable. Power of 2/5 in the right upper limb. And then we wrapped the limb loosely with cotton bandage and we rewarmed the limb over the next 8 hours. We tried to record the saturation, but the saturation was not recordable, indicating absence of blood flow. The perfusion index was not recordable in the right upper limb. The baby was started on low molecular weight heparin on admission. This was it after 8 hours. After we had rewarmed the limb, there was slight improvement in the blood flow in the forearm region, while the palm it had the same status. It was still discolored. On admission, the baby was vitally stable. There were no significant findings on systemic examination. Doppler of all the 4 limbs was done, suggestive of right upper limb, radial and ulnar artery showing no color flow, and they were thrombosed. Rest of the Doppler in the other 3 limbs were within normal limits. Routine investigations were sent, which were all within normal limits. Only the coagulation profile showed a PT of 14.6 seconds with an INR of 1.27 and a PTT of 64.9 seconds, for which the baby was given 1 dose of injection vitamin K. The baby was started on higher antibiotics like injection meropenem and vancomycin along with metronidazole to prevent sepsis and to prevent necrotizing fasciitis. Multidisciplinary involvement was taken and the decision to amputate the affected arm was taken. So on the 5th day of admission, baby underwent above elbow amputation, which was performed by the plastic surgery team. This was done once the demarcation line developed. The post-surgical period was uneventful. Baby was monitored for sepsis. As the septic screen was negative and blood culture showed no growth, antibiotics were stopped after 10 days. A low molecular weight heparin was continued on discharge. Regular dressing of the amputation stump is being done and the wound is healthy at present. Clinical exome sequencing for thrombophilia gene profile has been sent. So this is the amputation stump at discharge. It was healthy, no discharge was present, no bleeding, and the sutures were also healthy. The second case, a 13-day male child, same twin one of the same twin pregnancy. He was born in 36 weeks of gestation with a birth weight of 2.1 kg. He was brought to us on day 13 of life with complaints of discoloration of fingers of both the upper limbs noticed since 1 day, and this was after blood sampling in an outside hospital. No other complaints were present. So on admission, the baby showed discoloration of both the fingers of both the upper limbs, right as well as left. Baby was vitally stable, no findings on systemic examination. The Allen's test was negative, and there was no visible cyanosis or any discoloration in any other part of the body. The routine investigations were sent which showed thrombocytosis with a platelet count of 6.27 lakhs. The coagulation profile and arterial Doppler were within normal limits. Baby was started on low molecular weight heparin. Over the next 2 days, the discoloration improved and the baby had normal perfusion in both the upper limbs. A prothrombotic workup, that serum homocysteine, protein C, protein S, antithrombin 3, and factor V latent mutation are sent to the National Institute of Immunohematology at KEM Hospital. The reports are awaited. Mother's antiphospholipid and anticardiolipin antibodies were also sent in view of multiple first trimester pregnancy losses, which were also negative. At discharge, the baby was stable with no discoloration. He was on full feeds and on low molecular weight heparin. The third case, a 1-day male child born at 38 weeks of gestation with a birth weight of 3 kg. The baby did not cry immediately after birth, received bag and mask ventilation at birth. He was referred to Vadia Hospital on the same evening with edema and discoloration over the right upper limb below the midarm with query gangrene of the fingertips of the right hand. On admission, the baby was vitally stable and systemic examination showed no significant findings. So when the baby presented to us, on local examination, the right radial pulse was not palpable. The brachial pulses were weakly felt. The capillary refill time was 4 to 5 seconds and tenderness and swelling were present over the right upper limb. So this was the photo, this was the image when the baby had presented to us of the affected limb. Arterial Doppler was done, suggestive of right subclavian artery, PSV 24.6 centimeter per second with a triphasic flow. Right axillary artery showed a PSV of 46.6 centimeter per second triphasic flow. Brachial artery showed a biphasic flow, while there was no color flow noted in the distal brachial, radial, and ulnar artery with query thromboembolism with soft tissue edema. USC skull was within normal limits. Other routine investigations were sent which showed thrombocytopenia with a platelet count of 76,000. COVID antibody was reactive, 13.7. The coagulation profile was normal. Serum creatinine was slightly deranged with 1.28 and CRP was raised 64. So we consulted the anesthesia team and right upper limb brachial plexus block was given via the axillary approach with 0.25% bupivacaine. 12 hours after the procedure, we started the baby on injection heparin subcutaneously in 12-hourly dosing. Because for the sepsis, the baby was started on injection peptides and amikacin. And once after starting this heparin, clinical improvement was seen over the next 5 to 6 days with reduction in swelling, improved pulses, and capillary refill time over the next 1 week. So this was the image after treating the baby with heparin for a week. There was improvement in the perfusion as well as the pulses which were not felt before. We could feel the pulses. Later, the patient was having hematuria, so urine routine microscopy was sent, which was suggestive of plenty of RBCs and 8 to 10 pus cells. So we suspected renal vein thrombosis, and we did a USG abdomen with KUB along with the Doppler. So USG abdomen showed a hyperechoic lesion measuring 3.5 by 0.2 by 0.5 centimeters in the subcapsular region in segment 7 of the right lobe of liver. Along with this, there was a possibility of subcapsular and subdiaphragmatic hematoma with edematous left kidney and nephrocalcinosis. There was also a hypoechoic thrombus distending the left renal vein, extending into the renal, suprarenal, and the hepatic IVC. The USG, which was done before discharge, that was around 15 to 18 days after the admission, it showed a complete lumen occluding echogenic thrombus for a length of 0.7 centimeters in the proximal brachial artery, with distal brachial, radial, and ulnar artery showing low velocity blood flow with monophasic waveform. Proximal to the thrombus, the right axillary artery showed high resistance waveform with normal velocity, and there was a partial thrombosis of IVC and left renal vein with upper and lower pole influx with central liquefaction. So we had discharged the patient on injection heparin. He showed clinical improvement, pulses were palpable, and swelling had been reduced. So injection heparin had to be continued for at home, and review Doppler was done after 14 days. And we had planned a prothrombotic workup at 3 months of life because the baby was on heparin. The baby is following up with as an OPD, and this was the latest image, which showed a significant improvement in the color as well as the pulses and the edema over the affected limb. We had sent a clinical exome, which was suggestive of factor 13 deficiency, showing susceptibility to thrombophilia.
So just to summarize, we had 3 different cases in the last 4 to 5 months. The first pair was a set of twins, which was most likely showing an arterial thromboembolism kind of a picture. The first case, we wouldn't have gone ahead and done any workup, but then we had the second twin presenting with similar complaints and mother with having a history of multiple pregnancy losses. So we went ahead and sent an exome for the first twin, the reports of which are awaited. But they responded to low molecular weight heparin. Unfortunately, the first one had to undergo an amputation because the baby presented to us quite late with gangrene. Now, in the third case most likely seemed like a venous thromboembolism after ruling out hand presentation. But he did respond to the axillary block. And eventually he developed by day 2, day 3 of presentation, the baby also developed renal vein thrombosis type of a picture with hematuria. We did keep a suspicion of an infant of diabetic mother and sent the mother's HbA1c, which was within normal limits. And because there was no reason for this baby to have 2-site thrombosis, we went ahead with the exome. As far as sending the thrombophilia workup with us, we face a similar challenge because we end up starting them on low molecular weight heparin, and the reliability of the workup once starting it is questionable. And the second issue that we face is the hemat department always advises us to do this workup only beyond 3 months of age, again, because of reliability of the results. We find sending the exome a little more reliable because at least we have some kind of a diagnosis within 4 to 6 weeks of sending the workup. So yeah, that was the cases from Vadia Hospital.
Thank you, ma'am. Now I'll
Yeah.
request the AGPAI team to please take over.
So good morning, everyone. Am I audible?
Yes, Dr. Sajia, you're audible.
So myself, Fazia, first year neonatology resident at SGPGI Lucknow. I will be presenting discussion and approach to neonatal thrombosis under moderatorship of Dr. Abhishek sir. So we will be quickly going through some concepts related to developmental hemostasis then coagulation cascade and fibrinolytic system, risk factors for neonatal thrombosis, what are the various clinical presentation, what are the investigation, and how to do systemic, how to go for systemic anticoagulation, and the recent chest guidelines that are updated on March 2022. So coming to developmental hemostasis, coagulation factors do not cross the placenta because of their size, and these are produced in fetus starting at 11 weeks of gestation. In term neonate, concentration of procoagulant protein, particularly vitamin K dependent factors or gamma carboxylation dependent factors, including 2, 7, 9, and 10, and contact factors, these are reduced, and they reach adult value by 6 months of age. So when we look at coagulation factors in newborn, the vitamin K dependent factors 2, 7, 9, and 10, and contact factors including factor 12, 11, precalicrete and high molecular weight kininogen, these are reduced to varying degrees. However, fibrinogen, factor 5, 8, and 13 levels are similar to those of adult, and von Willebrand factor level is almost twice than that of adult. And there is predominance of ultra large form of von Willebrand factor. The ultra large form of von Willebrand factor is highly thrombogenic. What happens? The ultra large form of von Willebrand factor is cleaved to large von Willebrand factor in the presence of ADAMTS13 enzyme, and this enzyme is deficient in newborn or physiologically reduced in newborn. That is why there is predominance of high molecular weight form of von Willebrand factor. And when we look at anticoagulant protein, the antithrombin 3 is reduced by 50%, protein C and S are reduced by 60%. And although protein S is reduced, the protein S circulates absolutely in free form because of lack of C4b, that is the binding protein for protein S. Alpha 2 macroglobulin is approximately twice the level of adults, and the fibrinolytic activity is also altered. So in nutshell, the coagulation factors, vitamin K dependent proteins, and contact factors, these are reduced, which is compensated by high presence of von Willebrand factor and predominance of ultra large molecule of von Willebrand factor. Similarly, the anticoagulant factors, including protein C and S, are reduced. That is compensated by presence of alpha 2 macroglobulin. So overall, in a newborn, the hemostasis is finely balanced. So as we have already discussed, the vitamin K dependent and contact factors are reduced, and they will approach the adult level by 6 months of life. And most coagulation factor increase during gestation and postnatally, and therefore these are lower in preterm. So this is an article regarding the developmental hemostasis that was published in Maternal and Fetal and Neonatal Medicine Journal. So in newborns, there are factors that decrease hemostasis and there are factors that favor hemostasis. Factors decreasing hemostasis are platelet hyporeactivity, decreased platelet granule secretion, decreased level of vitamin K dependent factors as well as contact factors, and increased alpha 2 macroglobulin, that is a potent thrombin inhibitor. Factors favoring hemostasis are elevated hematocrit, high MCV, high von Willebrand factor, and decreased antithrombin 3, protein C, protein S, and heparin cofactor 2. So coming to phases of hemostasis in brief. So we have 3 phases of hemostasis. First is vascular phase, which starts with vasoconstriction of blood vessel at the site of injury, followed by platelet phase. The main aim of platelet phase is the formation of primary hemostatic plaque. It has 3 phases. Platelet adhesion, that is the interaction of platelet with subendothelium with the help of von Willebrand factor, followed by platelet activation and then platelet aggregation. Then comes the plasma phase. The main aim of plasma phase is the formation of secondary hemostatic plaque. It starts with initiation on a tissue factor bearing cell, like on the surface of monocyte and fibroblast. Then comes the phase of amplification and propagation, and during the phase of amplification and propagation, the coagulation cascade is transferred to platelet surface. So in brief, coming to coagulation cascade, the main aim of coagulation cascade is the formation of prothrombinase, that is the prothrombinase is the complex of activated factor 10 and activated factor 5. And for the formation of activated factor 10, we require tenase. So tenase can be of intrinsic, it can be formed through intrinsic pathway, that is known as intrinsic tenase, or it can be formed through extrinsic pathway, that is the extrinsic tenase. So the intrinsic tenase is a combination of activated factor 8 and activated factor 9, whereas the extrinsic tenase is a combination of tissue factor and activated factor 7. The important thing or aspect of coagulation cascade in neonatal thrombosis is understanding that extrinsic pathway is the main initiator of coagulation cascade, and intrinsic pathway is the main amplifier and propagator of coagulation cascade. This is important because extrinsic pathway is inhibited by tissue pathway, tissue factor pathway inhibitor, and intrinsic pathway is inhibited by antithrombin 3. Both antithrombin 3 as well as tissue factor pathway inhibitor are reduced in newborns. However, the reduction in tissue factor pathway inhibitor is more as compared to antithrombin 3. That is why extrinsic pathway is always initiator of coagulation cascade, whereas intrinsic pathway is propagator and amplifier of coagulation cascade. This is important in case of genetic causes of thrombophilia. For example, in case of protein C deficiency, what happens? The activated protein C is going to inhibit activation of factor 5 and factor 8. So in the absence of activated protein C, there will be uncontrolled activation of factor 8, and that will cause augmentation of intrinsic pathway and uncontrolled amplification and propagation of coagulation cascade, and that is going to cause uncontrolled or extensive venous thrombosis. So as we have discussed, tissue factor is the chief initiator of coagulation cascade, whereas intrinsic pathway is important for propagation and amplification. And as tissue factor is the chief initiator of coagulation cascade, deficiency of initiator of intrinsic pathway like prekallikrein, high molecular weight kininogen, they usually present with asymptomatic prolongation of APTT. So what happens once thrombin is formed? Prothrombin gets converted to thrombin. Thrombin will convert fibrinogen into fibrin, and then in the presence of factor 13, there will be cross-linking of clot. So once thrombin is formed, liver will synthesize thrombomodulin, and there will be formation of thrombin thrombomodulin complex that is going to activate protein C, and protein S will act as cofactor for protein C, and it will convert protein C into activated protein C. Activated protein C is going to inactivate factor 8 and factor 5. Coming to the fibrinolytic system. So the main aim of the fibrinolytic system is formation of plasmin, and plasmin is going to convert fibrin into fibrin degradation product. Plasmin is synthesized from plasminogen in the presence of tissue plasminogen activator and presence of factor 11, factor 12 as well as kallikrein. They also potentiate conversion of plasminogen to plasmin. Tissue plasminogen activator is inhibited by plasminogen activator inhibitor 1 and 2. Similarly, plasmin is also inhibited by alpha-2 macroglobulin and alpha-2 antiplasmin. So coming to thrombosis in neonates, greater frequency is seen at other times than childhood because we have seen that the hemostasis in newborn is finely regulated. It will affect artery as well as vein, and it has a predilection for major vessels. So coming to Virchow's triad that operates in adult, it also operates in newborn as well. So whenever there is hypercoagulability of blood flow stasis or vascular endothelial damage, then there is a risk for thrombus formation. Coming to different risk factors that are associated with neonatal thrombosis, these can be perinatal risk factor or postnatal risk factor. Perinatal risk factor can be maternal or placental or neonatal risk factor. So pregnancy itself is a hypercoagulable state, and the maximum hypercoagulability is found during delivery. So anything on the top of pregnancy will add on to this hypercoagulability phase. So what happens in case of infection? Maternal fever, inherited thrombophilia, antiphospholipid antibodies, these are associated with increased risk of neonatal thrombosis. Similarly, premature rupture of membrane, prolonged rupture of membrane, placental thrombosis and abruption, these are associated with the increased release of thromboplastin and perinatal thrombosis. Preeclampsia, hypertension, these are associated with increased activity of decreased fibrinolytic activity, and these are associated with thrombus formation. Similarly, primiparity, diabetes mellitus, dyslipidemia, they also create more procoagulant system, procoagulant phase, and they are responsible for neonatal thrombosis. In neonates, low birth weight, prematurity, severe fetal growth restriction, perinatal asphyxia, thick meconium, meconium aspiration, male gender, infection, and thrombophilia, these are the risk factor for neonatal thrombosis. Postnatal cause, anything that disrupts vascular endothelium, including infection, septicemia, in situ central venous catheter, or anything that creates hypercoagulable state, including thrombophilia, dehydration, polycythemia in congenital cyanotic CHD. Then in respiratory distress syndrome, it is seen that there is hyperactivation of tissue factor bearing cells like monocytes and macrophages that initiates the coagulation cascade. Use of steroids in premature babies, parenteral nutrition, and surgery. Pathophysiology of intrauterine arterial occlusive disease. It can be due to intrauterine compression or due to thromboembolic phenomena. Intrauterine compression can result from uterine anomalies, fetal malposition with limb prolapse, oligohydramnios, amniotic band, or umbilical cord entanglement. Thromboembolic phenomena can occur due to gestational diabetes, preeclampsia, dehydration, twin-twin transmission syndrome, IUGR, prolonged labor, or polycythemia. Coming to gestational diabetes and neonatal arterial thrombosis, apart from physiological hypercoagulability of pregnancy, in gestational diabetes, it is found that factor 8, factor 7, the amount of factor 8 and factor 7 is increased. And factor 8 and factor von Willebrand factor, these also act as acute phase reactant. They are increased, and decreased fibrinolytic activity is found in gestational diabetes, which may lead to arterial thrombosis in infants of diabetic mother. Coming to genetic causes, so the most common genetic cause is factor 5 bleed-in mutation. What happens in factor 5 bleed-in mutation? There is a point mutation at the binding where activated protein C is going to bind to factor 5. As a result, the APC cannot deactivate factor 5, and there is uncontrolled activation of factor 5, leading to uncontrolled proliferation of common pathway. Then factor 2 or thrombin mutation, that is G220-210A gene mutation. It does not alter the function of the thrombin. However, with this type of mutation, there is high generation of the thrombin generation is augmented. Then increased apolipoprotein A is seen to decrease the activity of fibrinolytic system. Similarly, hyperhomocystinemia will provide a milieu for procoagulant system and thrombus formation. Hyperhomocystinemia and all causes of hyperhomocystinemia like methylene tetrahydrofolate reductase gene mutation will lead to thrombus formation. Protein C and protein S deficiency are going to cause uninhibited activation of factor 5 and factor 8. Then again, they will lead to neonatal thrombus formation. Antithrombin 3 and heparin cofactor 2, these are potent inhibitor of thrombin. So in the presence of antithrombin 3 deficiency and heparin cofactor 2 deficiency, again, there will be more activation of thrombin and generation of hypercoagulable state. Dysfibrinogenemia and plasminogen activator inhibitor 1, 4G or 5G gene mutation. Plasminogen activator inhibitor 1, 4G, 5G gene mutation is a gain of function mutation of plasminogen activator inhibitor. As a result, a plasminogen is not going to convert into plasmin. So fibrinolysis is inhibited. Similarly, increased level of factor 8, 9, 11 or fibrinogen is also associated with thrombosis. Then antiphospholipid antibodies, including anticardiolipin antibodies, lupus anticoagulant. Chromosome 2q13 deletion. Chromosome 2q13 is a site for protein C synthesis or PROC gene. So in presence of 2q13 deletion, it will present with a phenotype of protein C deficiency. Coming to homocysteine metabolism. So homocysteine is produced from a metabolism of sulfur containing amino acid, that is methionine, which methionine through single carbon chain transfer reaction is going to convert into homocysteine, and homocysteine has two fate. it can either convert it to cystathionine in the presence of enzyme cystathionine beta synthetase and cofactor of pyridoxine, or it can get back converted into methionine in the presence of methionine synthetase enzyme. And vitamin B12 as well as 5-methyl tetrahydrofolate, they act as cofactor for methionine synthetase enzyme. However, 5-methyl tetrahydrofolate is generated from 5,10-methylene tetrahydrofolate in the presence of methylene tetrahydrofolate reductase enzyme. So in classical form of hyperhomocystinemia, there is deficiency of cystathionine synthetase or pyridoxine deficiency. Other causes of hyperhomocystinemia are methionine synthetase and a cofactor of methionine synthetase deficiency like vitamin B12 deficiency or 5-methyl tetrahydrofolate deficiency, that is which results as a due to defect or mutation in methylene tetrahydrofolate reductase gene defect. So what happens in hyperhomocystinemia? Homocysteine is going to decrease the anticoagulant activity of heparin sulfate, which is a potent thrombin inhibitor. Similarly, it decreases the cofactor activity of thrombomodulin. As a result, thrombomodulin cannot form complex with thrombin, and it cannot form a good activated protein C complex. As a result, the factor 5 is uninhibited. Homocysteine forms a complex with factor 5 known as homocysteinylated factor 5, and homocysteinylated factor 5 is resistant to degradation by activated protein C. Similarly, homocysteine is going to potentiate the activity of tissue factor, so it is going to initiate the coagulation cascade. Homocysteine also augments the activity of plasminogen activator inhibitor 1. So it also inhibits the fibrinolytic system and creates a prothrombotic state. Coming to various types of thrombosis, venous thrombosis in newborns, most cases are asymptomatic and detected incidentally, and mostly these are associated with central venous catheter. The earliest sign is the loss of patency of the catheter. Other signs include swelling or color change, and usually the draining part of the body is affected. For example, in case of symptomatic thrombosis in IVC, it will present as swelling of lower limb and lower body. Severity of the swelling depends upon the size of the thrombus. Long-term outcome of venous thromboembolic disease depends upon the location. For example, in case of portal vein thrombosis related to umbilical venous catheterization, long-term in pediatric age group, these babies may present with EHPVO and complications like portal hypertension. Sequelae of renal vein thrombosis include systemic hypertension, renal insufficiency, and renal tubular dysfunction. Coming to post-thrombotic syndrome, basically it is a complication of deep venous thrombosis. So what happens? Due to a deep vein thrombosis, there is persistent venous hypertension, and there is a backflow of blood from deep venous system to superficial venous system, and there is incompetent perforating valves. So clinically, and it leads to edema and impaired viability of subcutaneous tissue in an extremity. This is very rare in case of neonatal thrombosis, and clinically relevant post-thrombotic syndrome occurs only in 1% of neonates. Coming to right atrial thrombosis, most common causes again central venous catheter placement. In one of the studies, it was seen only in 5% of VLBW infants who had umbilical catheter. It can present as new murmur or heart failure as well as malfunction of catheter. Coming to portal vein thrombosis, so most common causes again umbilical venous catheterization. Most cases are asymptomatic and regress spontaneously. Report rates of PVT range from 22 to 75%, whereas spontaneous resolution at 1 year was more than 95%. Majority of portal vein thrombosis were asymptomatic. Again, the long-term complication include hepatic lobar atrophy or portal hypertension. In a retrospective study of 74 patients with neonatal portal vein thrombosis, only 4% patients experienced complication of portal vein thrombosis, and 60% had complete resolution over a follow-up of 16 months. Coming to renal vein thrombosis, It accounts for 10% of venous thrombosis in newborn, and it is the most common form of thrombosis not associated with the vascular catheter. Proposed mechanism include reduced renal blood flow, hyperosmolality, hypercoagulability, and increased blood viscosity. So risk factors again include prematurity, perinatal asphyxia, or anything that produces hypercoagulable state, including dehydration, polycythemia, cyanotic CHD leading to polycythemia, sepsis causing endothelial damage, sepsis and shock. Then respiratory distress syndrome causing activation of tissue factor or release of tissue factor from fibroblast cells, and maternal diabetes. Prevalence of inherited thrombophilia is higher in infants with renal vein thrombosis, and RVT may be unilateral or bilateral with or without extension into the IVC. And typically there is a triad of RVT, that is flank mass, hematuria, and thrombocytopenia. However, in one of the case series, it was seen that the complete triad was seen only in 13% of patients. Coming to arterial thrombosis, the most common cause of arterial thrombosis is the presence of arterial catheters. And the incidence of arterial thrombosis is associated with arterial catheters, and it is variable. Prophylactic heparin infusion may reduce the risk of thrombosis. Coming to perinatal arterial ischemic stroke. So perinatal stroke, it refers to an insult, ischemic or hemorrhagic, occurring from 20 weeks of gestational age to 28 days postnatally. And there should be a brain imaging confirming a parenchymal infarct in the appropriate arterial territory. Most abnormalities, they occur in left hemisphere within the distribution of left MCA, and placental pathology is a major risk factor for perinatal ischemic stroke. So this is the image showing the blood supply of the brain. So from this internal carotid artery, we have middle cerebral artery. We have three parts. This is the initial part is M1 part. Then as it curves through the sylvian fissure, this is the M2 part. Then the cortical branches of MC are M3 part. And these M3 part is the most common site for perinatal ischemic stroke. So the current chest guidelines, they recommend that anticoagulation for neonates with perinatal ischemic stroke should be considered only if there is evidence of cardioembolic source or there is evidence of recurrent PAIs. And MRI with diffusion weighted imaging is the most sensitive technique. Coming to umbilical artery catheter related thrombosis. So the incidence varies from 8% to 20%. Most of the USC associated thrombosis are asymptomatic, and some present with signs of severe ischemia or organ dysfunction. And depending upon the location, signs are coolness, poor perfusion, blanching of a toe, one or both limbs, or the buttocks. Sometimes hypertension may be present, and in some cases, it can mimic severe aortic coarctation. Then if the thrombus extends into renal, mesenteric, or branches of spinal artery, it can lead to renal failure, NEC, and spinal cord infarction. However, these are very rare scenarios. Peripheral artery occlusion, incidence ranges from 3 to 63%. Clinical signs include decreased or absent peripheral pulses, diminished perfusion, prolonged capillary refill time, cool pale extremity, and diagnosis is confirmed by Doppler ultrasound. Coming to purpura fulminans, this is characterized by disseminated intravascular coagulation and extensive hemorrhagic skin necrosis. Most common cause of purpura fulminans, most commonly in inherited thrombophilias, these are associated with homozygous or compound heterozygous deficiency of protein C or protein S, and usually there is family history of neonatal purpura fulminans. However, in case of other causes of consumptive coagulopathy, including meningococcemia, we can also find the signs of purpura fulminans. Coming to investigation, these are done for looking complication and for etiology. So for look for the thrombus as well as the extension of thrombus in major arteries and veins, including aorta, IVC, or right or renal vein. MRI if cerebral events are suspected, then ABI or ankle brachial index or Doppler pressure index is calculated. Normal value in newborn, it should be more than 0.88. Doppler ultrasound, coming to imaging, Doppler ultrasound method is most frequently used, and it is a non-invasive imaging modality. However, the contrast angiography, it remains the gold standard, specifically when thrombolytic therapy or surgery is planned. So these are the images, ultrasound image of right kidney. This is showing a thrombus in right renal vein that is extending to IVC. Similarly, in left kidney, there is loss of corticomedular differentiation, and we cannot see any communication between renal vein and IVC. So here small renal venules are involved. And this is an ultrasound image and color Doppler showing thrombus in IVC. This is an ultrasound image showing complete portal venous obstruction. This is porta hepatis. This is complete portal venous obstruction. And this is a CECT of the same patient showing the complete portal venous obstruction. And this is an ultrasound image showing cavernoma formation that is secondary to complete portal venous obstruction. And this is CE MRI image showing cavernoma. So for diagnosis of vascular thrombosis in case of central venous line associated thrombosis, though Doppler ultrasound is the initial investigation method, contrast angiography remains the investigation of choice. In case of right atrial thrombosis, echocardiography is the diagnostic imaging. In case of pulmonary thromboembolism, lung perfusion scan is the imaging of choice. So when to test for congenital thrombophilia? Whenever there is significant thrombosis, including spontaneous thrombotic events, unanticipated or extensive venous thrombosis, ischemic skin lesion and purpura fulminans, and a positive family history of neonatal purpura fulminans. Coming to thrombotic workup, it should be done for activated protein C resistance and total protein C concentration. Activated protein C resistance means that activated protein C is not going to lyse factor 5 or inactivate factor 5. Total and free protein S concentration, factor 5 lead-in mutation, prothrombin mutation, antiphospholipid antibodies, causes of hyperhomocystinemia, level of homocysteine as well as methyl tetrahydrofolate reductase gene mutation and antithrombin concentration. So this is a recommendation from American Society of Hematology, whom to test any neonate or children with non-catheter related venous thrombosis or stroke, then testing for thrombophilia should be done. In case of newborn with symptomatic catheter related thrombosis, recommendation, there is no recommendation, not enough data to make a recommendation. And in neonates or children with asymptomatic catheter related thrombosis, testing is not recommended. So the only recommendation is in neonates with non-catheter related venous thrombosis or stroke. And in neonates or children participating in thrombosis research, testing is also recommended. So there are two types of testing, level 1 testing and level 2 testing. Level 2 testing is done when the level 1 tests are normal and thrombophilia, despite of that, thrombophilia is suspected. So in level 1 testing, we have DNA testing that are for testing for genes or mutation like factor 5 lead-in mutation, prothrombin 20210 mutation, and methylene tetrahydrofolate reductase gene mutation. And we have protein assays that include protein C deficiency, protein S deficiency, AT3 deficiency, antiphospholipid antibodies, and elevated lipoprotein. So factor S is in newborn. What are the fallacies? This is because, as we have seen, due to developmental hemostasis, both protein C, protein S, antithrombin 3, these concentration are reduced in physiologically low in newborn, and they reach at a normal value by 6 months of life. So that is why most of these investigations are repeated 3 to 6 months, after 3 to 6 months. Levels are physiologically reduced in newborn. In homozygous protein C deficiency, it is easily diagnosed in neonates because the levels are undetectable. However, heterozygous protein C deficiency is difficult to diagnose because, so this has to be repeated after 6 months. Similar to protein C, protein S, the total protein S level is comparatively low in newborn. However, the free protein S is more because the binding protein is less in newborns. Homozygous proteinase deficiency is very low or undetectable and it is easily diagnosed. But heterozygous proteinase deficiency, the test should be repeated after 3 to 6 months. Plasminogen level at birth, these are approximately 50% of adult value. Homozygous plasminogen deficiency does not appear to be associated with thrombosis. So this test need not be done in case of neonatal thrombosis. Then antithrombin 3 is again reduced and they will remain reduced for at least first 3 months of life. Then other test, gene mutation, factor 5 lead-in mutation, prothrombin 20210 mutation, and babies with of women with SLE or APLA may infrequently develop thrombosis due to presence of antibodies. So these are indicated only if there is maternal history. Coming to treatment. So there are 3 options in management of neonatal thrombosis. One is anticoagulation with the help of unfractionated heparin or low molecular weight heparin. The other is thrombolysis with recombinant tissue plasminogen activator. And the last option is vascular microsurgery. So whenever there is acute limb ischemia, there can be 4 different scenarios. One is irreversible, that is gangrene along with demarcation. So the only option we are left with primary amputation. In case of obvious extremity arterial trauma, non-ischemic surgical repair can be done. Then we have 2 more conditions. One is obvious extremity arterial trauma, threatened limb with absent Doppler flow. In case of absent Doppler flow, we can go for thrombolysis. Along with that, we can start systemic anticoagulation. And the other condition is borderline ischemia, non-threatened limb, partial neurological deficit with CFT of more than 3 seconds. These are the candidates for systemic anticoagulation. So in case of obvious extremity trauma with absent Doppler flow, medical management and catheter-directed tissue plasminogen activator can be given and vascular reconstruction can be considered. In case of compartment syndrome, fasciotomy should be done. When there is borderline ischemia in non-threatened limb and partial neurological deficit with CFT of more than 3 seconds, we should start systemic anticoagulation. Then catheter-directed thrombolysis can be considered. Or systemic thrombolysis for short time may be considered, and systemic or local vasodilator can be used. Coming to systemic anticoagulation. So most commonly used systemic anticoagulation are unfractionated heparin and low molecular weight heparin. Coming to unfractionated heparin, the advantages are short half-life, rapid dose adjustment, early discontinuation, and low cost. Disadvantages are low level of antithrombin in physio, because unfractionated heparin, both low molecular weight heparin and unfractionated heparin, they are going to act through antithrombin 3. And the physiologically antithrombin 3 is reduced in newborn. That is why high doses are required. Apart from that, the volume of distribution is more in newborns, as well as clearance is also more in newborns. That is why the dose is high. 24-hour IV access is required, and there is risk for heparin-induced thrombocytopenia. Coming to mechanism of action. So when we look at unfractionated heparin and low molecular weight heparin, the pentasaccharide sequence is common to both, and this pentasaccharide sequence is required for binding to antithrombin. So both unfractionated heparin as well as low molecular weight heparin will bind to antithrombin 3, and then they will inhibit factor 10. But apart from inhibiting factor 10, unfractionated heparin is going to inhibit factor 2 also. That is why it is a more potent inhibitor of coagulation cascade. So in case of unfractionated heparin, the therapy is monitored either by anti-10A levels, 0.3 to 0.7 international unit per ml, 4 hours after administration, or APTT activity of 1.5 to 2 times the normal value. Then the desired anti-10A level is 0.3 to 0.70 units per ml. In this case, we continue the dose, and if it is more than 0.85, we have to hold the unfractionated heparin for 1 hour, and we have to recheck the level and restart the infusion and decrease it from baseline by 10 unit per kg per hour. Coming to low molecular weight heparin, Advantages are reduced risk of hemorrhage, no need for IV access as it is given subcutaneously, reduced monitoring requirement, and lesser risk of hit. Disadvantage is longer half-life. So whenever there is short-term anticoagulation is desired, especially if surgery is indicated within next 72 hours, then unfractionated heparin should be used. And in case of long-term anticoagulation, low molecular weight heparin is more practical. Coming to side effects, the most common secondary effect include bleeding or heparin-induced thrombocytopenia. HIT is usually, it is of two types, type 1 and type 2. Type 1 is non-immune mediated and type 2 is immune mediated, that is due to antibody formation against heparin platelet factor 4 complex. HIT usually present 5 to 10 days after heparin initiation. However, there is an entity called as delayed HIT that present beyond 2 weeks of starting heparin. The other very rare complication include osteopenia that are rare due to inhibition of osteoprotegrine. That is very rare in case of newborn. And a very rare complication is hypoaldosteronism. If bleeding occurs, discontinue the drug and we can administer protamine sulfate. The dose is 1 milligram of protamine per 100 international unit of heparin. IV, it should be given through IV infusion over 10 minutes. For low molecular weight heparin, the goal of the anti-10A level, it should be maintained between 0.5 to 1 international unit per ml for therapeutic indications. And for prophylaxis usage, it should be half, like 0.1 to 0.3 international unit per ml. So for low molecular weight heparin, the goal is to maintain the factor anti-10A level of 0.5 to 1. And when it is beyond more than 1.5, we have to hold the next dose and decrease the dose by 50%. Contraindication for coagulation include central nervous system surgery, ischemia, active bleeding, invasive procedure within 3 days, seizures within 48 hours. And relative contraindication include a platelet count of less than 50,000, hypofibrinogenemia less than 100 milligram per 100 ml, INR of more than 2, a severe coagulation factor deficiency or known allergy to an antithrombotic agent. Coming to thrombolytic therapy, so it should be considered in the presence of extensive thrombosis when organ or limb viability is jeopardized. Thrombolytic agent act by converting plasminogen to plasmin, which in turn cleaves fibrinogen to fibrin and fibrin degradation product. Streptokinase and urokinase were used in past, and the recent chest guidelines, it recommends only the use of recombinant tissue plasminogen activator. And streptokinase and urokinase are not recommended because of highly allergic potential. So recombinant tissue plasminogen activator most commonly used because of its short half-life, minimal antigenicity, direct activation of plasminogen, lack of inhibition by alpha-2 antiplasmin, and localization of fibrinolytic activity. How to administer tissue plasminogen activator? Most often it is administered systematically. However, it can also be given locally. There are two different types of regimen. One is high dose infusion, that is 0.1 to 0.6 mg per kg per hour over a period of 6 hours, and it is usually done in case of extensive venous thrombosis or arterial thrombosis. And there is a low dose regimen that is 10 times lower, 0.01 to 0.06 mg per kg per hour for up to 48 hours for venous thrombosis. So for monitoring thrombolysis, we have to do imaging studies of the clot every 4 to 24 hourly. Cranial ultrasound should be performed before initiation of treatment and then every 24 hourly. And once clot lysis is achieved, the recombinant TPA therapy should be discontinued. Coagulation values before initiation of treatment should be done, and then every 24 hourly this should be repeated. The desired fibrinogen level, it should be 100 milligram per 100 ml. Platelet count should be a minimum of 50,000, and plasminogen and D-dimer should be adequate to achieve thrombolysis. Contraindication for thrombolysis include active bleeding, invasive procedure within 3 days, seizures within 48 hours, neurosurgery in previous 3 weeks, severe asphyxia, invasive procedure in previous 3 days, gestational age younger than 32 weeks, severe septicemia, active bleeding at the time of therapy. Coming to surgery, the goal is to maximize the chances of limb salvage, and normal limb growth. So they are a combination of microsurgical techniques and thrombolytic regimen. Surgical thrombectomy is necessary if larger vessels such as abdominal aorta is involved. In case of compartment syndrome, decompressive fasciotomy can be done. Then mechanical disruption of thrombus using soft wires and balloon angioplasty along with side-directed thrombolytic therapy can be done. And the last option in case of gangrene along with a demarcation line is amputation. So when thrombophilia is highly suspected, like in case of purpura fulminans or family history of purpura fulminans, protein C concentrate should be given if it is available. The dose varies between 20 to 60 IU per kg. The mean dose is 40 IU per kg every 6 hourly. It should be continued for 6 to 8 weeks. Followed by, they can be shifted to oral anticoagulant. If not available, fresh frozen plasma at a dose of 10 to 20 ml per kg should be given. Target protein C level is more than 0.25 unit per ml. Coming to topical nitroglycerin. Topical nitroglycerin has been demonstrated to reverse peripheral and umbilical artery catheter-induced ischemic injury. The mechanism of action is that nitroglycerin is converted to nitric oxide, which relaxes the smooth muscle, and the dose is 4 mm per kg dose of 2% nitroglycerin ointment. Pharmacokinetics of nitroglycerin, the drawback is that it have not been studied in neonates, and vasodilation may lead to hypotension and transient decrease in blood pressure. These are reported in 2 case reports.
Fauzia, sorry, I think you're doing pretty good, but we are running over time. So if you can wrap up just salient important thing in the remaining presentation, and then we need to have a 5-10 minutes of discussion to summarize all this. So just quickly wrap up. Yeah.
Okay. So finally, coming to chest guidelines 2022, these are American College of Chest Physician Evidence-Based Clinical Practice Guidelines. These are updated in March 2022. So as we have discussed, for unfractionated heparin, the anti-10A activity level, it should be maintained between 0.35 to 0.7. The dose of unfractionated heparin, the bolus dose is 75 to 100 units per kg, followed by the maintenance dose. It is in less than 2 months, it is 28 units per kg per hour. In low molecular weight heparin, the target anti-10A level is 0.5 to 1 unit per ml. The therapeutic dose is 1.5 mg per kg per dose subcutaneously 12 hourly, and the prophylactic dose is 1.5 mg per kg per dose every 24 hourly. For a central venous access device associated thrombosis, chest guidelines recommend for asymptomatic cases immediate removal of the catheter. For symptomatic cases, anticoagulation for a period of 6 weeks to 3 months, initially by unfractionated heparin, followed by low molecular weight heparin, or we can start with low molecular weight heparin. And for limb threatening cases, thrombolysis along with tissue plasminogen activator is recommended. And they recommend fresh frozen plasma infusion prior to thrombolysis. In case of renal vein thrombosis, in case of unilateral renal vein thrombosis without extension to inferior vena cava, supportive care can be given. And in case of bilateral renal vein thrombosis or unilateral renal vein thrombosis extending to IVC, anticoagulation with unfractionated heparin followed by low molecular weight heparin or LMWH, starting from LMWH, it should be continued between 6 weeks to 3 months. For bilateral renal vein thrombosis with evidence of renal impairment, initially tissue plasminogen activated thrombolysis followed by unfractionated heparin or LMWH for a period of 6 weeks to 3 months is recommended. In case of peripheral arterial catheter related thrombosis, chest guideline recommend continuous UFH infusion of 0.5 units per ml at 1 ml per hour.
Fauzia.
Yes, ma'am.
Fauzia, I think you should wrap it up. It's already 9:15.
Okay, ma'am. Then again for CSVT, the recommended duration of anticoagulation is between 6 weeks to 3 months. In case of AIS, the treatment is recommended only in case of recurrent AIS or in case of cardioembolic source for a duration of 6 weeks to 3 months. In case of neonatal purpura fulminans, 10 to 20 ml per kg of FFP, it should be administered. A protein C concentrate at a dose of 20 to 60 unit per kg it should be given whenever available. So take-home messages are most thrombosis in NICU are catheter related, and for prolonged systemic anticoagulation, LMWH is the drug of choice. Duration of systemic anticoagulation is between 6 weeks to 3 months. And workup for thrombophilia is indicated in any newborn with non-catheter related venous thrombosis and stroke.